Tunneled established vascular access devices, or EVADs, have some distinct advantages over non-tunneled catheters. There's less chance of them becoming dislodged. Also, the tunnel and the cuff on the inside decrease the rate of infection by providing protection from pathogens entering the vascular space. Tunneled catheters can stay in for a longer period of time compared to their non-tunneled counterparts, in some cases for several years. Here you can actually see the tunnel and the subcutaneous tissue on the model. It's really nice when the type of catheter is this obvious, but unfortunately it's not always like that. So your best chance to figure it out is to ask the family or the patient what kind of catheter they have. There are so many different kinds of tunneled catheters, and although they look different, they behave very much the same and are accessed the same way. Ultimately, the patient and the family will be able to provide the most helpful details for a particular device. Let's say your patient has an access that looks similar to this. This is actually a Groschon catheter. So there's a few questions that you need to ask and have answered in order to be able to access it. First, determine if the device is even viable. Next, get the patient's permission to access the device. And finally, contact medical command, provide all your pertinent findings, and receive the order to go ahead and access the device. To determine if the site is viable, take a look at the site real closely. Look for any signs of infection if there's redness or swelling at the site. Do your best to gauge the temperature of the site if it's hot, or if there's any signs of infection you wouldn't want to access it. You'll also want to know when the last time it was accessed. If it's been a month since the last time it was accessed, you'll probably want to avoid using it. Many of the tunnel catheters you'll encounter begin their entry into the subcutaneous tissue somewhere in the chest wall. Then they'll usually make entry into the vascular space through the internal jugular. The catheter is then situated so that the distal tip is in the vena cava just above the right atrium. The Save That Line acronym from the Association for Vascular Access will help you to remember some important principles when accessing any established vascular access device. The S in Save That Line stands for scrupulous or strict hand hygiene. Hand hygiene is the basis for all of infection control. I always say treat these catheters like you're taking your paramedic test. Keep everything strictly clean and avoid any risk of air emboli. Each and every time you connect to the catheter, make sure that you clean with a fresh alcohol prep. You're going to do that for 15 seconds. Also, if it's equipped with a clamp, make sure the clamp is closed before you attach and detach from the catheter. This will help you to avoid any risk of air emboli. You notice how I'm scrubbing the hub with a lot of friction? Well, that's the V in the SAVE technique, vigorous friction to the hubs. To be in compliance with strict aseptic technique, don't reuse the saline flushes. Make sure that you use a new saline flush each and every time you connect to the port. When accessing EVADs, never use anything smaller than a 10 cc syringe. Research has shown that smaller syringes have higher pressures and could damage a catheter. Because this tunneled Groschon catheter is probably heparinized, we're going to waste about 8 cc's. So I've expelled about 8 cc's of saline from this syringe. The reason I leave a couple cc's in the syringe is to avoid any risk of air emboli. And now we're going to attach our syringe, making sure that the clamp is closed before we attach and then opening it once we're attached. And then the last part of the save technique is E for ensuring patency. You can see that we got a great blood return here, so we've definitely ensured patency. Make sure that you close the clamp off before you remove the syringe. Now that we've successfully ensured patency, we have to begin again. So we're going to grab our alcohol prep, our brand new alcohol prep, making sure the line is closed off. And we're going to clean the hub with vigorous friction for about 15 seconds. Then we can reattach our 10 milliliter saline flush. Remember, we don't want to use anything smaller than a 10 milliliter because of increased pressures. We're going to unclamp our line, and then we'll flush the catheter using the push stop method, where we push 1 milliliter of saline and pause briefly and then continue to push until about 8 to 9 cc's of normal saline has been flushed through the catheter. The reason we want to leave at least a milliliter of saline in the syringe is to avoid any possibility of air emboli. Once we flush the catheter with enough saline, we're going to clamp it off and remove the syringe. Unfortunately, it's not uncommon for a catheter to develop partial occlusion, such as a fibrin tail like the one shown here. The symptoms of a partial occlusion are poor or no blood return and difficulty or poor flow when flushing. If you encounter this in the field, it's best not to use the catheter, unless the patient is in extremis and there's no other access available. To complete our access and make things a lot easier, we're going to hook up a bag of saline. So just follow the steps in the video.